In this video, we're going to look at patellofemoral pain syndrome, or runner's knee, as most people call it. What we're going to look at is a quick recap of how can you tell if you've got runner's knee. Then we're going to look at some of the myths around what exercises you should be doing and if you should really be focusing on specific bits of it. And lastly, we're going to share some top tips for when you're doing your exercises, how to prevent flare-ups and why it may be that your exercises aren't working that well for you. So for those of you who don't know me, my name is Marika. I'm one of the physiotherapists from sportsinjuryphysio.com, where you can get online physiotherapy for your injuries. But today with me, I have Brodie, who's from the Run Smarter podcast, and he's a physiotherapist from Australia, and he's also recently started his own YouTube channel. So Brodie, welcome.
Marika, thanks for having me on. I'm excited to have a chat today.
Yeah, so tell me a bit about yourself, because if somebody has a Run Smarter podcast, it usually means they like running. So what's the connection there?
Definitely. Well, I started off, I was a physiotherapist before a runner, and I graduated in 2012. And about 5 years into my physio career, I became a recreational runner. And I just had a huge passion. Once I became a runner myself, helping treat runners in the clinic was a big passion of mine. I'd be buzzing every time a runner would come in, and I'd help educate them, help get them back to pain-free running, and bust a lot of myths along the way, because there's a lot of misconceptions and there's a lot of confusion around how to overcome a certain injury, how to prevent certain injuries, how to increase performance safely. And so that just propelled me towards distributing a lot of information, and that led to the Run Smarter podcast, and has now led me into the YouTube channel, just to have another platform to help communicate and help runners, survive and thrive.
Yes.
And so it's just me just following my passion, and that's where it's left me today. I've got the Run Smarter physiotherapy clinic, which is an online physio clinic. And so everything that I'm doing now is just helping the runner and helping educate them as best we can.
Yes. And the funny thing about being a runner yourself is what I found was a lot of the stuff you read in the book for how it should work, you realize that actually there are ways around it, that you can stay active and that you can continue with things. But yes, so Brodie did a brilliant series about of videos about patellofemoral pain or runner's knee on his channel. So I really want you to check that out if you haven't already. But we're going to highlight some of those things. And I had questions for Brodie about some of the stuff that he spoke about in his videos. So if we can jump in, Brodie, can you just quickly tell us, how can you tell if you've got runner's knee? What are the typical symptoms of it?
There are some pretty common characteristics that some can find with overlapping symptoms. Some people might have something, some people might have others, but there are general guidelines and general common symptoms that people can have. Most common among them would be symptoms around either the border of the kneecap, or what we call like the undersurface of the kneecap. And it can be a bit hard to describe where the pain is. Most people, if they have, say, ITB syndrome, or if they have an Achilles tendinopathy, they'll take one finger and they'll point to it and say, this is where my pain is. But with patellofemoral pain, it's kind of hard to point with one finger. They sort of trace their finger like around one part of a border or around the other part. And essentially it's a little bit ill-defined in terms of location. And so describing the location of the pain can help describe or give an accurate estimation of diagnosis, but then also what produces pain. So we know that if you suspect patellofemoral pain, you'll need to have pain with at least one of these tasks that strain the patellofemoral joint. So we're looking at things like squatting, lunges, stairs, anything that puts load through the knee as the knee bends. If that produces pain in that location we're talking about, tends to be honing in on our accuracy that it's patellofemoral pain. And some may have what we call crepitus, which is like an awful sounding clicking or sort of grinding underneath the kneecap itself. And so some people can have that, some people don't have to have that. So that's why we sort of find those first two common characteristics. And then again, we look at the history, we look at what caused it in the first place, and if it's due to a pattern of like overloading the joint in the first place that at the time that the pain arose, then it again hones in on our accuracy.
Yeah, no, absolutely. I mean, it's so funny in the clinic when you start testing somebody, they always want you to find that bit that hurts. And then you go through all the tests for the meniscus and for the ligaments and everything, and nothing hurts. And you can see their face just fall. And you go, no, that's actually diagnostic. The fact that none of these things hurt means it's okay. It's probably just going to be runner's knee. Now, myths. I really want to chat about the myths, because when you did that video, I thought, yes, somebody else is saying this out there. Because if somebody tells me, or a patient comes to me one more time with, I need to strengthen my VMO, and the exercises you're giving me, but they're not activating the VMO. Tell us what the VMO is, and do you need to activate the VMO?
Yes, it's we can't blame people that, I guess, have that stuck in their mind, because I was taught that when I graduated. Like it was the understanding at the time, and it was assumed that a lot of the patellofemoral pain arose because of a muscle imbalance, and a lot of the time like the kneecap was tracking poorly within its groove, and that sort of produced this particular pain. And so the theory being that the VMO, which is just these very fine fibers that attach onto the inside of the knee, so it's a part of your quadricep muscle, but it's along the inside of the thigh that attaches onto the inside of the knee. If you strengthen that particular part of the quadricep muscle, that might help in controlling the position of the knee, and therefore can help reduce the patellofemoral pain and then reduce its occurrence in the future. And so a lot of research, or a lot of suggested treatment that we do, is isolating that VMO, trying to get someone to activate those fibers in order to strengthen and control that particular pain.
Well, before you go on, can I just ask, how frustrating do people find on a level of 1 to 10 to try and activate the VMO on its own?
Well, when I first graduated, I sort of was told how to communicate to activate these fibers. You know, think about doing this and press your heel down. You should feel like a tension underneath the thumb. And no one could get it. And I'm thinking, maybe it's my communication, and maybe it's something that I'm doing wrong. And turns out that it's just a whole bunch of bogus. And so I'm glad that research has now come out to show you don't need to do that. It's unnecessary. And like you say, it's extremely frustrating.
Yeah. I just found that it demotivates patients, because they can't get it going, and then they go, well, this is never going to get better because I can't activate my VMO. And yes, fine, there was the research that showed that the VMO is less active when you have patellofemoral pain syndrome, but it's because the pain inhibits it. And luckily, like you said, now the research has shown that actually if you just do the regular exercise and strengthen the quads, it comes back in any case. The other one I want to talk about is the IT band being tight.
Yeah, it's like extending away from patellofemoral pain and just talking about the ITB. There's a lot of communication, and especially around runners. My ITB is too tight. I need to release it. I need to do foam rolling, massage ball, and especially if they've been told by health professionals that, oh, you have a really tight ITB, and they sort of get worried and obsess about trying to release it because it feels tight. And when they put a foam roller on, it feels really sore, and they're like, oh, it's so tight. And we sort of create this belief, and we sort of create this narrative that this really tight structure needs to be released. And the belief when it comes to patellofemoral pain, again, they thought that the premise of the condition was the position of the kneecap, like drifting away from its groove and sort of creating this malposition or malalignment. And the weak muscle, the weak VMO, sort of drifted it across. But also the tight ITB on the other side might have helped to drift it across. And this was my understanding when I first graduated as well. Let's release the ITB and tighten the VMO to bring that patella back into position. And, then you just go back to common sense. Okay, what is this ITB? What is the structure? Well, it's not muscle. It's not ligament. It's not tendon. It's fascia. And the fascia itself doesn't have any contractile properties. It doesn't contract and relax like a muscle or a tendon would. And it's this thick, dense fascia that's actually meant to be tight to help support you when you're standing on one leg. And so if you didn't have that tight, your hips would drop and you'd sort of flop, your knee would collapse. It sort of acts as this buttress sort of force to hold you in place passively. And the structure itself is so thick and it's so fibrous, you can't possibly release it. You can't even possibly release it by stretching or by rolling a foam roller on it or pushing a massage ball against it or doing these sorts of things. It doesn't physically release anything. It might make things feel better, which is why we sort of are very careful with when to prescribe things or not, because some people can roll their foam, do their foam roller on their ITB, and their knee pain gets significantly better.
Yes.
It's not releasing, it's not getting longer, but their pain's getting better. So we need to really make sure of when to include it. But if we do include it, making sure we're not following that poor narrative of my ITB is really tight, it needs to be released. Maybe there's something else going on that inhibits the pain, which will only be short term, but might be crucial in someone's rehab. So we don't want to discredit it, but we want to make sure we're not following the poor narratives at the same time.
Yes, and I guess you've touched on a really important issue there as well, which is how things like massage and foam rolling can definitely change pain, but it doesn't do all the things that we traditionally, you and I were taught to do. We were taught that you can rub things, that you change the pliability of the tissue, that you change the consistency of the tissue, you take knots out of the tissue, you can get rid of scar tissue by rubbing it. And now we know through the research that actually, no, it doesn't do any of those things. Yes, your pain feels better, but it's because the touch and the foam rolling affects the pain cycles and it decreases your pain. And like you said, pain is a very important part of allowing you to get on with rehab or things like that. So I agree with not dissing it totally, but just not focusing on that too much then.
Yeah,
so if we move on from that to exercises for, I nearly said fight band syndrome, exercises for runner's knee, patellofemoral syndrome. Now, Brodie's done a whole video about progressive rehab for it. But Brodie, I think it's important that we explain to people what progressive rehab is, just in a nutshell, and why is that important? Why can't you just do 5 exercises and do them for 3 weeks and then you can go back running?
It's really important. It's a really important topic because people need to understand that when you irritate an area, the reason why people get patellofemoral pain in the first place is because they've overloaded that joint. They've done squats, lunges, running, a HIIT class, an exercise session, something that's overloaded and exceeded the capacity of that joint. So we know that in vast majority of cases, that is the primary driver. And once it's irritated, once it's quite sensitive and once there's heightened levels of pain, that capacity that it could once withstand is now diminished. So what was once an innocent negotiating up a flight of stairs is now painful because that capacity is lower. And so the idea with rehab is to establish your current adaptation zone, your adaptation sweet spot. What can you currently tolerate that doesn't exacerbate symptoms, but still has the purpose of contributing to your strength? And if it's really irritated and you've had it for a very long time and you've mismanaged it for a long period of time, that capacity might be really low. Some people might start, quite high because they've only had it for a couple of days, it's only very mild and there's not a high level of sensitivity. And so you need to find where on that spectrum you can currently tolerate. And once you've found that, really important that we train within that and then progress to eventually get up this, what we call rehab ladder, to whatever your goal is. So that might be return to running, that might be returning to a 5-minute pace 10K, that might be returning to hills, that might just be trying to get upstairs, it might be squatting or picking up your kids, it might be something functional like that. But we need to make sure that we find that adaptation sweet spot to start with, and then slowly progress to achieve those goals, because you might start off with exercises that are really basic and keep doing those and you feel a lot better. And then you get back to squatting, lunging, stairs, running, and symptoms come back. And it's only because you haven't treated that rehab ladder, you haven't negotiated or bridged the gap between capacity and irritability. And so very important that progression's in place so that it's a safer return and it's reducing the risk of a flare-up once you're back to those activities.
Absolutely. And if I look at 99% of the time when people tell me I've done exercise, but exercise doesn't work for me, then it's either going to be that they started with exercises that were obviously making their pain worse, so they didn't go for the capacity that was right for them, or they've actually done it for a couple of weeks, the pain went away, and they used that as a signal that, oh, I'm ready to go now, and they didn't bridge that gap, like you said. Okay, so then I have asked Brodie to share some tips with us, go a little bit more in depth into some of the exercises that he shows in that video of his. And the first one there that you demonstrate is for the really initial stages of rehab for runner's knee, which is isometric wall sits. So what I want to know is why isometrics, and why are you doing it in the way that you're doing it, and what are the pitfalls with that exercise? Because it's a really simple exercise, but also easy to get wrong.
Yeah, I started off this as an example because this is probably the most basic exercise that I start with, and it can be modified to make it slightly easier. But like I say, someone might start off with more challenging exercises because that might be their sweet spot. But I just want to start off, if you're really irritable and you're not too sure where to start, this is probably a good place to start. We do isometrics because, well, we do it as a starting point anyway, because if the patella itself is quite irritable, then moving in and out of that position and trying to engage with some quad work might irritate things. It might irritate things. And so a safe option is just to hold that position and make sure that you're activating your quads, so we're getting really strong in that muscle activation, but doesn't irritate the knee. That's essentially the goal of rehab to start with. It's to try and strengthen, try and contribute to extending that capacity, exceeding that capacity, but without irritation. And so wall sits are quite nice because they help control the range of movement. If you were to do a squat and try and hold this position, you might be shaking and you might not get the range of movement as correct or as reproducible. And so wall sits, I find, is a really nice start, and just trying to find what range of movement is a really good start. So some people might want to start here and find that it produces a little bit too much discomfort in the knee. So then you can just simply move higher up in the wall, and there's less bend in the knee, and therefore it's a good starting point. So it's good to try and establish what might be the right modification for how sensitive your knee is right now.
And would you typically tell, absolutely. Is there anything that you would tell people about, because I've seen people go into the wall squat and then their heels are against the wall versus far out from it. What's the ideal place for your feet to be placed?
I guess to start with, I like to have the feet quite far away so that when you squat, the shins achieve like a vertical position. And so if your knees, you need to understand, the more bent your knees are, the more load is going through the patellofemoral joint. And again, that we'd say that's not bad, but it might not be the best starting point for you. Because we know that knees going past the toes is quite functional. We need to eventually train the knee to tolerate that. But in these initial stages, moving the feet further away, making sure the feet are about hip width apart, and then trying to get the shins close to vertical would be a nice starting position for most. And so that's probably most of the advice I would say.
Yeah, and I guess it comes down to, again, it depends on how irritated your knee is. So that is the position where there'll be least pressure going through the knee, and therefore it will be least likely to flare it up. But as you get stronger, it will tolerate more of that. The other exercise that people use a lot for it, and which is obviously one that we should use, is loaded squats. Now, is there anything specific with regards to squats that you feel is worth sharing, that you see people make mistakes that flare people up, or are there any myths around it that you want to share with those?
There's a lot of variety with squats. There's a lot of, I guess, different positions and different things that you can do with squats. Maybe if I show like on a bench, you can have something that, let me move myself a little bit further back. So if we were to do something like a squat, we can use weights, or we can start with body weight, and we can find something that's, I guess, the right height to control the range of movement. And so if you're doing squats, if you've eventually progressed to doing squats and you want to do weighted squats or body weight, we then need to say, okay, what range of movement should we go through? Similar to the wall sits, is there a certain range that we can tolerate and progress beyond that? So you might have a high bench, and then when you squat, you just touch that bench and then come back up. And this is sort of where you're finding your balance. When you squat down, the knees coming past while the shins are going a little bit beyond vertical. So we're putting a little bit more load through that. But it's just as simple as seeing what you can tolerate, seeing what sort of irritability there is. And if there is low irritability and you want to progress, we can simply do the same range of movement, but just add weight. Or we can keep the same weight and decrease the height of a bench or the height of a chair to then increase the range of movement.
Yeah, because if you add the weight, you're going to essentially load the joint more. Whereas if you make it lower, you're also going to load the joint more because it's going to work through a bigger range of movement. So that's perfect. And I'm glad you explained what you meant with the right height, because that's going to be my next question. You keep on saying the right height. What's the right height? But yes, it's basically the height that a person can tolerate so that they don't feel too much pain when they do that. Is there anything else that you want to share today with regards to exercises?
With regards to exercises, I would say try not to change too many variables at once. When we progress things, we want to progress one variable at a time. So in the case of a squat, you wouldn't increase the weight and increase the range of movement at the same time. So that's a particular thing that we need to try. But when it comes to progressions, we want to move beyond double leg stuff and into single leg stuff, particularly if we want something that's quite functional, particularly if you have, if we want to negotiate stairs, if we want to go back to running, if we want to go back to lunging, all of these things are single-legged exercises, and we need to sort of train the knee to tolerate that, because a single leg exercise is essentially double what the load is required for a double leg exercise. And so it's very important that we train and adapt and bridge that rehab ladder to make sure that we're accommodating for those things.
And then when you get people to go back to running, so that's the other place that I find the wheels come off.
I think it's plain and simple. People just don't understand the load that goes through your knees. They're kind of underestimating how much load is required for running, how much strength is required for running. And especially when you've had a history of patellofemoral pain and you're just getting back into things, it's enormous. Like every step that you take is 2 to 3 times your body weight in load going through that knee joint, every single step. And so we really need to respect it. We really need to make sure that your return back to running is very gradual. Want to make sure it's a very conservative start. I usually start people with a walk, run rotation for returning back to patellofemoral pain, or returning back to running from patellofemoral pain, and monitoring symptoms along the way. And so that can be particularly tricky for those who aren't too sure about pain levels, what's acceptable, what's not acceptable, and making sure that we're guiding through what is acceptable, how to interpret symptoms, and then responding to those accordingly, and making sure that we're keeping on track of everything.
So you mentioned you use a run walk program when you get people back, and that's exactly what I do. And I always explain to them that the walk bit is kind of like your 1 to 2 minutes rest that you would have after a strength training set that you've done, that everything can just recover and go on, and then you build the endurance slowly like that. But you mentioned that people need to look at their symptoms and monitor their symptoms. So what do you typically advise people when they do find that actually they did a run walk session today and it increased their symptoms in the 24 hours after? How should they react to that?
A very important question, and a very important topic if someone wants to manage and overcome patellofemoral pain. And this comes not only to running, but also your strength training and your rehab and your cross training. These pain guidelines pretty much are similar across the board. And I say to my runners, when you're running and when you're exercising, you want to make sure the pain level is less than a 4 out of 10. So your ones, or a 0, 1, 2, 3 is what we call acceptable. But it's acceptable during that exercise if it then abides by the following pain guidelines afterwards.
Yeah.
It needs to settle quite quickly. And for most, I would say it needs to return back to baseline within 24 hours. If it's back to baseline in less than 12 hours, then we're really safe. But if you're noticing at your baseline symptoms, it might not be pain-free. It might be a 1 or a 2 out of 10 pain going upstairs in the morning. That might be your baseline.
Yeah.
So then if you do a run and you do your rehab and the next morning you do those stairs and instead of a 1 or a 2, it's a 3 or 4, that is an example of something that hasn't returned to baseline, and something you have done the day before has been too much. And so we want to make sure that we're following all of these pain guidelines. The third one that I like to put in there, which isn't in the research, is making sure your symptoms improve week by week. So looking at a longer time frame, because some people can say, oh yeah, I'm tolerating this run or these exercises well because I'm back to baseline, but they've still been in pain for 6 weeks.
Absolutely.
And we want to follow a bit more of a longer term trend to make sure things are getting better week by week.
Very well, Brodie, thank you so much. This is a really useful video. And like I said, Brodie's got a brilliant YouTube channel that he's just started up. There's lots of useful videos, especially about runner's knee at the moment. And then if you've not checked out his podcast, how long have your podcast been going on for?
It's approaching about 3 years and about 240 episodes. So there's a lot of information.
I mean, you are insane with how many episodes you put out in a week. I remember looking at it going, what? How many is he doing? So yes, there's lots of useful information on those podcasts as well. The Run Smarter podcast, Run Smarter web YouTube channel. And then if you want help with an injury, Brodie does online sessions in Australia. We're in the UK side, but we all work pretty much all over the world as well. I'm going to put links to everything below in the description of this video. So if you want a link to anything, you'll find it in there.